Welcome to Shift Report, the podcast brought to you by EMcentric.com. EMcentric is the go-to information and resources hub designed exclusively for the emergency medicine community. On each episode of Shift Report, we host key leaders from the field who share their insights and experience from inside the world of emergency medicine. Our goal is to inform you, to encourage you to use what you learn to improve your practice and to improve yourself. Today, we welcome Dr. John Jones. Dr. Jones practices in Northern Virginia. He received a medical degree from George Washington University, where he also trained in emergency medicine and completed fellowship training in pediatric emergency medicine at Inova Fairfax Hospital. Today, he'll focus on the challenges of managing an emergency department as part of a local Democratic contract group, while sharing some insights on how he manages the hectic mix of clinical and non-clinical roles we know so well. Welcome, John.
Thank you, Till. I appreciate you having me on the podcast today.
Yes, and thank you for taking the time to share some of your insights with us. So you've got a wide range of experience in emergency medicine, like many of our listeners. So just sort of for starters, what led you to emergency medicine as a career?
You know, I did med school at George Washington, and my original plan was to be a neurosurgeon. And I'd spent time in the neurosurgery service, and it just didn't have necessarily the thing that I was looking for. And I spent time in the emergency department at GW, and that was kind of what clicked with me. I enjoyed the wide variety of patients. I enjoyed the fact that we would take care of infants, and then we would take care of trauma patients, and we would take care of every age range. And I think that's kind of what got me stuck on emergency medicine. Also, I grew up on a farm in Nebraska, and my version of a physician was family practice. And emergency medicine, in my mind, was kind of the closest version to family practice. It all fit. Been doing it for over 20 years now.
That's great. That's a version of a story that I think will resonate with many listeners. Along the way, you clearly had mentors and people who guided you and advised you. Who were some of your key mentors, either in the clinical space or not in the clinical space?
Yeah, I kind of break that down into, different phases of my life. So in residency, it would be Jim Scott, who was my residency director. And then quite honestly, Till, it would have been you as well. Till, to the listeners out there, was my attending at George Washington, and then also one of my attendings at Fairfax. During my PEDS fellowship, Rick Place, Maybell Koo, the director of the pediatric emergency department, and the fellowship director. And then from a leadership standpoint, probably Scott Friedman, who is the chair of pediatric emergency medicine at Shady Grove. And then from a hospital standpoint, I think Gene Christian, who is the chief medical officer at my current hospital, which is Inova Fair Oaks. So those are kind of the people that I think have influenced me over my career.
Great. Thank you for that. I didn't solicit that compliment, but thank you. And I think we all, I know the people you mentioned, and I think we all respect them and respect their contribution to our careers. Now, you head up a group called VEMA. Tell us a little bit about the group and tell us about the hospitals where you work.
Yeah, so VEMA, Virginia Emergency Medicine Associates, Democratic group, small Democratic group. We're one of 8 Democratic groups in the Commonwealth of Virginia currently. The group was founded, I think, in 1988, and we have 2 ED contracts, so Inova Fair Oaks, Fairfax, Virginia, and then Fauquier Hospital, Warrenton, Virginia. And then we also staff the hospitals program at Inova Fair Oaks. And our total encounters per year is about 110,000. We have 60 providers and then probably another 60 part-time providers. And that includes APPs, nurse practitioners, and physician assistants, as well as hospitalists and then emergency physicians as well.
In the industry, there's lots of discussion of contract management groups, CMGs, and there are lots of them. Many of us know who they are. So when you are around the industry, when you're talking in business settings, when you're talking with hospitals, how do you differentiate yourself from contract management groups, and how does that affect how you manage your physician and APP staff?
Yeah, I think that the large differentiator between us and contract management groups is physician and provider autonomy. So being a small group, everybody has a say in what happens, regardless of whether you're a shareholder or not in a group. And everybody knows who the leadership team is because they work with them in the clinical space. So all of our physician leaders work in the emergency department or on the hospital service, probably approximately 2/3 full time. And I think that the advantage of that is that one, our physician leaders understand truly what's going on in the department because we're there. I use the phrase, we eat our own cooking. And then also it tends to give credibility with the other services because again, we are working in the department as well as with the nursing staff. And I think that that piece of having physician leaders who are in the clinical space is important. The autonomy and the decisions that are made locally, we have the ability to add staffing, change staffing, and change on a dime. And I think that piece is very important for the responsiveness for our hospital partners as well as for our patients. And I think probably those are the main things that I would think about and what differentiates us from a large contract management group. I mean, we don't necessarily have the scale of large contract management groups, but we can offer a kind of an individual touch to our physician or our hospital partners.
So you lead a group in a large suburban area, but a relatively small local group focused on a smaller number of hospitals. And so what, other than just the scale, what challenges do you face sort of managing a local group like that?
Yeah, our initial challenge was that there are a large amount of complexities, both from an HR side as well as RCM, so revenue cycle management, and then compliance. And we were doing it independently. We were doing it on our own with a series of consultants. And probably about 2 years ago, we pivoted and used R1 for practice management. And it's interesting is that they will manage a larger number of groups. So we have now the ability and access to some of those consultants that we didn't necessarily have before. So we have HR consultants who are specific toward healthcare. We have financial advisors who can help us do financial modeling as far as best opportunities for staffing. We have an RCM partner through R1 where we can see trends within payers. So I think that as a small group, it's important to partner with larger entities in order to get that scalability. So while we might appear as a small group, I think that we have the services and resources that any CMG does as well. And that's mainly through strategic partnership.
That's great to hear. And you're essentially running a small business in a space where there are lots of large businesses. So finding those resources is important. There are lots of new graduates who are thinking about where they want to work, what they want to do. A new graduate comes to you and is looking for a job or just looking for advice based on your experience. What do you tell that graduate when considering a group like yours or a larger group or an academic center or other options they may be looking at?
Yeah, I first start with a conversation with them that your first group isn't necessarily going to be your last. And it's very common for a new physician to start in one group and then 2 or 3 years later move to another group. And I want them to understand that. And then when I talk with them about what are important things to look for, I think they kind of have to dig down and find out what's important to them. I will say geography is a really important piece as well, because if being in a certain area is important to them, it might limit what opportunities that they actually have. So if they want to be in a Democratic group, but they can only be in a certain city, they might not necessarily have an opportunity to join that Democratic group. I would have them reach out and ask about what is physician autonomy, what is the scheduling, what are the provider metrics as far as expected patients per hour. I think the right numbers are probably about 1.8, maybe 2, depending on the acuity of the patients that you're seeing. Anything above that, I am concerned that it might lead to lower patient satisfaction numbers and you might miss something. I would counsel them and say, don't go for the highest dollar job, go for the job out there that has a work-life balance that is good for you. And that's a combination of compensation, because that's important, but then also what are the other pieces that are going to make you whole as a physician? And those are the things that I talk about. I mean, in general, the rest of it is almost kind of the same. The malpractice policies in general are the same now. Everybody offers a tail policy. The compensation, relatively close. The benefits are relatively close. But you have to look at what is that work-life balance, because I look at emergency medicine as a marathon and it's not a sprint. And when you first get out, you feel like you can see 1 million patients, but that's not sustainable.
That's great advice, and you know, comes from over 20 years of experience in doing this. So, and I happen to know that you've done some extra business education and gotten your MBA, but you didn't have it when you were first managing this kind of thing. So, you know, emergency medicine is facing a number of challenges, business personnel and otherwise. You know, before COVID, there was a burnout issue, and now there's even more of one. There are dropping reimbursements. There's the No Surprises Act, which some people may know about. And there are probably other challenges that aren't on that list, but are there, you know, top of mind for you. Where do you see the specialty headed?
Yeah, I think the No Surprises Act is probably something that's going to have to be sorted out, and it's most likely going to have to be sorted out on a government policy level. So just a quick background for those that aren't aware. So the No Surprises Act, I think, was instituted in 2022, and it was passed in order to decrease or eliminate out-of-network billing, specifically for hospital-based systems where patients didn't necessarily have a choice. So they show up in the emergency room, they don't know if the group is in network or out of network, and quite honestly, it doesn't matter because they weren't given that choice anyway. And the No Surprises Act was put in place to protect those patients from specific out-of-network billing, which on the face is a good thing for the public. Instituting it has been problematic. And it's been problematic for a couple of reasons. One, for groups that had specific out-of-network strategies, they had significant drops in reimbursement. So that's one piece of it. The other piece is I think that the No Surprises Act has also emboldened the insurance companies as far as downcoding, even for groups that are in network, as well as not necessarily aggressively negotiating new contracts with providers. So if we think about the pendulum of reimbursement, it has definitely swung in the other direction. And I suspect it'll probably swing back to the middle, but that's going to take some time. And I'm probably thinking a couple of years until it all gets sorted out. I think that the intent of the No Surprises Act was good. I think the implementation has been challenging.
That's a great analysis. Thank you. So we spent some time talking about matters germane to emergency physicians, but members of the public utilize our services and need our services and may not understand exactly what goes on in an emergency department before they show up. There are different levels of providers. There are physicians, there are physician assistants, there are nurse practitioners, and then they'll get bills from the patients will get bills from more than one place in most cases. So who are the staff in the emergency department and what should the public know about who they are and how things work?
Yeah, and this is a great source of confusion for people. So we'll use our hospital in Nova Fair Oaks. So in Nova Fair Oaks has the emergency department, but VEMA, Virginia Emergency Medicine Associate, has the contract to provide physician services in that emergency department. So when a patient comes to the emergency department, they will be seen by a VEMA provider. They will receive a bill from the billing company that represents VEMA. That's called a professional fee. They will also receive a bill from Inova. That is called the facility fee. And a lot of times that causes significant amount of confusion for patients because they're like, well, I saw a doctor at the hospital. Why am I getting two bills? And that's the reason for it. As far as the differing levels of providers in the emergency department, so there are advanced practice clinicians or advanced practice providers, which are either nurse practitioners or physician assistants or physician associates. And they will see patients in the emergency department. They are usually picking patients that are geared more toward their skill set or their comfort level. And then the rest of the patients are seen by a physician. And I want the public to know that the APPs are have oversight by the physician. So in our group, the APPs have constant conversations with the physicians about the care of the patient. So while the physician might not necessarily see the patient face to face, the physician is always aware of what's going on with that patient in the emergency department. Wait times tend to be problematic for people, and the wait times vary. I would like to say that Mondays are always busy. They usually are always busy, but what we've seen post-COVID is that every day can be busy and some days are not busy. Sometimes I am particularly surprised on the days that are busy and that are not busy. And I will say we're doing the best we can to get people back and get them seen, get their care expedited. Emergency medicine has transitioned to using different systems in order to get them back, and it is constantly attempting to innovate to provide faster care and better care. I mean, it's a great specialty to be in because we are actively trying to improve care every day, which makes me thrilled.
So we talked a bit about some of the challenges facing the specialty, burnout, staffing, and otherwise. I mean, what should the public know about the challenges that emergency medicine is facing, and how that might affect them at a micro level, and how that might affect their community at a more macro level?
Yeah, so physician burnout, and specifically emergency medicine physician burnout, is a large problem. So emergency medicine physicians have the highest rate of reported burnout, and it's about 65%. So that number is real and needs to be addressed. And physicians within the specialty were attempting creative ways in order to help physicians as they navigate their career, which can be quite challenging. Why is it challenging? It's shift work, and that can be tough on having a family. It is challenging in that it can be quite stressful as far as making life and death decisions on a regular basis. Workplace violence is becoming very common in the emergency department. And in our hospital, the ER has one of the highest rates of workplace violence of any department in our hospital. And well, what does workplace violence mean? It can be something as simple as microaggression to providers. It can be actual physical violence. And I think that is donating to burnout as well. I would ask the public from a workplace violence standpoint, give us a little grace sometimes. We're trying, doing the best we can.
Certainly understood. And I think, I don't think any of us want to tolerate workplace violence. And I think the public maybe see law enforcement around and think that, that's an indicator of something, but that's not necessarily an indicator of what might happen. It could be anybody. And you're right. It could be kind of microaggression to physical violence. And it's a different environment. So you probably get questions from neighbors, friends, and otherwise when they're going to the emergency department. I think we all do. And so what one or more thing do you want members of the public to know about when they visit the emergency department for whatever reason?
One, we are there to take care of you. That's why we're there. Some people almost apologize for coming to the emergency department, and I tell them, this is why we're here. This is our job. This is what we committed to. So when people come to the emergency department, we are there to take care of them. That's what our job is, 24 hours a day. The wait times can vary. We don't always necessarily offer a definitive diagnosis. Sometimes our job is more the approach of what is life-threatening, what requires them to be hospitalized, what requires immediate intervention, and then a handoff to the outpatient world. The outpatient world is under their own set of stress right now. We understand and frequently see that it's difficult for them to get in to see certain specialties and receive certain tests. And we try as best we can to collaborate with those specialties, but there still are challenges of access. So I think, again, we're there to take care of them. This is what we do and what we can't necessarily do. And then again, ask for a little bit of grace. We're doing the best we can sometimes.
And sort of back to, we talked a bit about workplace violence, and we talked about challenges and burnout and other things. So there are lots of emergency providers facing all sorts of stress in their work environment, or perhaps outside their work environment that they then bring with them. What advice do you give to people on your staff or on other staffs about taking care of themselves in the environment that we've chosen, and making sure that the career is rewarding and safe and enjoyable?
Yeah, from a group leadership standpoint, the thing that we focus on is staffing metrics. And again, we don't want people to be seeing too many patients. It's a marathon, not a sprint. So from a ED physician leadership, I think setting the expectations of staffing is important. I think from a hospital leadership, removing as many barriers to care as possible. And I think that's an important piece. We love to do our jobs, and probably what causes us the most anxiety is that when we know what needs to be done, but we can't navigate the system in order to do it. And I think that, you know, with engaged leadership on a hospital level, removing those barriers one by one can make it a better environment for people to work in. And then, sorry, Taylor, what was the last part of the question?
So I think just you know, advising individuals on how to take care of themselves, psychologically, physically, and otherwise in a tough work environment.
Yeah, so I think on a personal level, I think recognizing this is a hard job and there are things that we see on a regular basis that in essence can cause versions of post-traumatic stress disorder. I mean, our group, we bring in a physician advisor who does wellness with our physicians. And I think acknowledging that and making sure that that's an important piece of your group is something that's also going to extend the longevity of careers. Also remember that the way that people feel well or determine resilience differs from person to person. So there isn't necessarily a one-size-fits-all approach to wellness. And I think that it has to be tailored to what works for that individual. And that's on leadership to figure out and provide those resources.
Well, thank you. This has been a wonderful download of information for our audience. And thank you for taking the time to speak with us. And I'd like to thank you for joining us in this installment of our EMcentric podcast series. And special thanks to Dr. Jones for sharing his important insights. For more content, networking, and innovation in the world of emergency medicine, please visit EMcentric.com. Thank you.